All right, so good morning, everybody. Once again, my name is Jim Pavlik. I'm the Senior Program Policy Analyst at the Behavioral Health and Wellness Program at the University of Colorado Anschutz Medical Campus, PHWP for short. And we are the institution, the organization that has the contract to provide technical assistance in the domain of cessation. So as you might imagine, if this is your first learning community call, having said what I just said, that we work a lot with and support the QuitLine as much as we can, or I should say promote the QuitLine as much as we can. Joining me today to talk all things QuitLine are Keith Cooper from STEP. He's the QuitLine, is it manager, Keith?
No, technically it is a cessation intervention coordinator.
Cessation Intervention Coordinator, and Katie Carradine from National Jewish in the QuitLine. So I don't know who wants to get us kicked off here. Who makes the most sense? Because I'm going to be talking data.
I think we'll start. Yeah, I think we'll start with Katie going over a little QuitLine. I'll talk about how you all can access your local data, and then Jim will talk about a little bit about how you might utilize some of that data.
Absolutely. Katie, thank you. Thank you. Thank you for joining us, Katie. I'm so
You're
happy
welcome.
to have you
Good
here.
morning. Good morning. Thanks for having me. I always love to listen in on these, but really honored to actually be part of it and present. So I do have slides. I'm going to rock through them pretty quickly, but wanted to talk about overall program updates with the QuitLine. Certainly, Colorado QuitLine is constantly innovating and changing and all the great things. So I'm going to present a little bit on that today. I'm going to share Jim, can I share my screen?
Oh, yeah. Let's do that.
Here we
Okay.
go. Perfect. All right. Let me know if you guys can you see the slides? Just a thumbs up. All right, awesome. So again, like as we talked about, I'm going to be presenting on Colorado QuitLine today. Just a little background, National Jewish Health is a top-ranked respiratory hospital. The QuitLine is actually part of the department within the hospital. We have partnered with Colorado Department of Health since 2002, so a long-standing partnership with our friends in Colorado. I have this slide. There's a lot of information on this slide, but I really just wanted to visually give you a picture of all the updates and new things that have happened in the Colorado QuitLine community over the last 22 years. I couldn't believe I could capture it all in one slide, and I probably missed a few things, to be honest with you. But I'll share these slides with you, Jim, afterwards, and we can share them out with the team so that they can see them in more detail. I'm going to walk through some of the more recent changes to the Colorado QuitLine so that everybody is aware of all the really cool things happening. So Colorado QuitLine, we have several ways in which you can now refer to the QuitLine, which is really important. You can certainly self-enroll. Participants can self-enroll on the web at coquitline.org, 1-800-QUIT-NOW. We have fax referrals and web referrals for not only HIPAA-covered entities like clinics and hospitals, but also for community organizations. So that's a new thing that we have a community organization page within the website now that allows you to refer. It is because it is a non-HIPAA covered entity. You will not receive information back about the participant, but you'll certainly receive some sort of confirmation that we've received your referral. Certainly through e-referral, and we now have what we call a text me first feature. That's really important when you're referring participants or telling people how to refer participants, that they ask for consent to text and fill that out on the referral form. That will then send the participant a welcome text that says, good, that you've been referred to the Colorado QuitLine. We're really excited to help you. If you want to learn more about the QuitLine, click here, and there's a link to a participant video that people then can then watch and get immediately engaged from the point of referral. We find that then engages them into the QuitLine information, and they're easier to engage when we do reach out and call them to get them into the program. So I wanted to really highlight that piece on the referrals as well as the community referrals that are now available. Not much here has changed. 5-call program, unlimited inbound support calls. We do have phone, web, text, or email, or NRT, and they are standalone services. So if somebody just wants to be involved in the email support system, they can select just email. If they want just NRT and don't want to actually have to talk to anybody on the phone, that's also an option through the Colorado QuitLine as it is now. They still have to be at least 18 years or older to receive NRT. That's an important piece of information. I just want everybody to know, even with a doctor's note, we will not provide minors with NRT. And we have lots of specialized programs that I'm going to kind of quickly review here in the next few slides. Again, just a few different additions to the enrollment pages so that we could really highlight those. You can see now that we've really broken out each service as a standalone service. So they can select all of these, they can select one of them, they can select whatever smorgasbord works for them on their quitting their way is really the attempt that we're sort of trying to relay here at the enrollment page. There is also coaching via chat on the website, so that can engage them over a chat instead of a phone call. And there's now a new text to order NRT option. So if they engage in the text program, they will get a text about maybe 2 weeks into their quit journey, whether it be on the phone or whether it be on the web, that will offer them a one-time engagement to order NRT over text. So again, just an additional way to kind of keep them engaged in the program and keep them engaged in their quit journey. A little bit about our special programs. I always think these are really important to go over, especially because there's additional programs that have been added. The American Indian Commercial Tobacco Program is not new, but it is always highly important to review. It's a 10 coaching call program with a American Indian coach. It is a tailored program. It is a specific coaching program that we have created. It is up to 8 weeks of NRT is offered. It has its own standalone website as well as its own standalone phone number. But please understand that if they call 1-800-QUIT NOW, they still have access to the American Indian program. They don't have to call the specific American Indian phone number. That is really used for ease of marketing, and wanted to make sure that they had additional support. The pregnancy postpartum program is also not new, but I always want to highlight it. Pregnancy postpartum program is a 9 coaching call program with 5 coaching calls during pregnancy, 4 coaching calls postpartum. Our coaches do an incredible job of engaging the pregnant people throughout the program, as well as offering that really intensive additional support postpartum. This is an incentivized program. They receive $20 for each completed pregnancy call and $30 for each completed postpartum call. That is on a Colorado QuitLine visa that is sent directly to the participants in the mail. It is with the same dedicated female coach throughout their entire program. This is our only dedicated coach program. And the reason we do that is because we really want to build that deep trust and rapport with people who typically think they're going to be shamed or judged if they're engaging with somebody that understands that they are pregnant and using tobacco. This program, again, is with a female QuitLine coach. That is how it was built back in 2010 and remains that way today. My Life, My Quit. Here's our fancy map. I have to color in a few more states on this map, but Connecticut, Missouri, and Nebraska are also in part of the My Life, My Quit program. We now serve this program across 26 states in the country. This is our youth cessation program for anybody under the age of 18. This is, Colorado was one of the first supporters. That's always a nice little brag moment of this program back in 2019 when it launched. And a sneak preview for you, we have revamped the program. The new My Life, My Quit program will be launching in the spring of 2025. It includes a full overhaul on the website and the actual coaching protocols with the coaching. This will engage youth via text. Currently, right now, it engages youth on short code text. They can engage with a coach, live texting 24 hours a day, 7 days a week. And we've made some changes to the coaching protocol so that we can then outreach additionally to the youth once they've engaged with us on text. So everything, most 90% of this program is offered over text message or chat. It is available for phone purposes. Some youth do prefer to talk on the phone, surprisingly, but it's a very small percentage. Most of them are over text, and we are constantly training our coaches to decode text short code and slang and all words sus and bro that comes across via text messages. Not all of our coaches are youth coaches. It's a subset of our coaches. They go through rigorous quality reviews on their chat, on their text report to make sure that it is youth friendly, that it is youth specific, and that youth really feel welcomed when they come into My Life, My Quit. It's a simplified registration process. We are not asking insurance questions. We're not asking if they have COPD or if they have any sort of medical demographics that we need to understand. The only medical demographic question we do ask under the youth intake is if they have asthma. And that is really just a request from some of our state health departments to make sure that we can track youth asthma. There is specific promotional and educational materials for youth. Everything that is in the youth program is tailored to youth. So the text library is tailored to youth. Again, the live texting with a coach is all youth friendly. And this program is available 24 hours a day, 7 days a week. It does have its own website, mylifemyquit.com, and it mimics the adult website where there's provider resources, there's educational resources for teachers, certainly for parents and guardians, as well as a youth-friendly website to engage on educating themselves on the use of nicotine products. Off of our youth program came our young adults program in 2021. This is 18 to 24-year-olds can also engage. You will notice that it is the same short code for youth as it is for young adults. That was not us trying to be efficient or cost effective. Really what we wanted to do is make sure we had one marketing place of short code for kids in high school. Quite frankly, we know that high schoolers don't stop at 18. So 36072 is also the short code for the live texting with a coach. Young adults can access that. They can also access the young adults program through the regular 1-800-QUIT-NOW phone number. This program is slightly different than the My Life, My Quit program, as while the entry points into the program are the same, they have the ability in this program to order NRT, which is not something they can do in the My Life, My Quit program. Launched in November 2023. I tried to tell you, Colorado's been very busy with all these program ads, is the new menthol protocol. The menthol protocol is tailored coaching for all menthol users, talking about really the disproportionately targeted groups affected by menthol, how it's more addicting, all of the things that our coaches do to support and understand each menthol user. This is an incentivized program as well. So they'll get incentives for calls 1, 2, and 3 within the program. What we find is that obviously the longer we can keep them engaged in coaching, the higher our chances are of having a successful quit. So our data shows that when we incentivize the menthol users through those first 3 phone calls, the engagement and the retention into the program is substantially longer. So they are incentivized. It's the same Colorado QuitLine branded Visa gift cards that are sent to them. And they are actually eligible for 16 weeks of NRT. That includes combination therapy. So it is an extended amount of NRT to support the more intensive quit approach. The other special program that we have is our behavioral health program. Our behavioral health program covers up to 7 behavioral health conditions. We find that we have about a 70% opt-in rate of this program of participants that have behavioral health concerns. This is a self-identified behavioral health concern. This is not, I don't need a formal diagnosis from a doctor. I don't need any sort of blood work or paperwork to say, oh, you have a behavioral health condition. If they say they suffer from anxiety and they would like some additional support, then they are opting into this program. This is an opt-in program. They can opt in or opt out of it at any point, but it's a more intensive approach. It's a 7-call program. It really talks about mood management and managing some of the challenges that may come with some of their behavioral health conditions while quitting the use of nicotine products. It offers up to 8 weeks with combination therapy as an option in this program of NRT. And as you can see, we have some higher engagement within the program through those 7 calls. Calls 6 and 7 are really support calls about 30 days after their call 5, so that we can prolong the support that they have within the QUIT program. was really fast and furious. So if you have any questions, Jim, I wanted to be under the allotted time, and I could go on for hours about the QuitLine. So if you have questions, please let me know.
Oh, I plan on being so brief. You have plenty of time, but
Oh,
should we should we should we pause for questions now? I think that might be a good idea. There was a ton of material in there. Maybe not. Uh, Katie, you might have said it, but when does what is the young adult upper cutoff?
oh, 24. It's a great question. 18 to 24.
And then I assume that after they type in the short code, they get a greeting. At some point, they're asked to say their age so that you know which way they're being routed, since it's the same short code.
Yeah, it's a great question. So anytime they enter the short code, so if they text start or quit or whatever to 36072, there's 4 automated questions. The first one is, what is your age? We cannot ask date of birth. Obviously, that's PHI and it's not over a secure text. So we ask, what is your age? What is your state? What type of tobacco do you use? And I think it's a readiness to quit question. The last one's a readiness to quit. Once they answer those 4 questions, there's a summary text that says, okay, I understand you're 18 from Colorado. You use vaping and you're ready to quit today. Is that correct? Hit yes or no. You hit yes. And then it will say type coach to talk to a coach, or text tips if you just want more tips. If they text tips, then that will basically enroll them in the text library for either youth or young adult based on their age. At that point, what will happen is they will get 2 to 3 motivational texts a day, or not a day, excuse me, a week. 2 to 3 a day would be a little aggressive, don't you think? And in those text libraries, there's video links to learn more about the program, or there's calls to action throughout that text library. At any point, once they've done that, even if they've text tips, they can still text coach and it will be directly connected to a live coach. The live coach will then say, oh, great, I have all your information here. If you're interested, let's get started. And then they'll send them a secure link. That secure link will be an enrollment form either into My Life, My Quit based on age or the young adults program. And then the coach will engage with coaching once that form is completed.
Awesome. And then with the American Indian program,
Yep.
do you try to match tribal or national heritages, or is it sort of more just Native American more broadly?
It's a great question. So it's more broadly. We have, think I think we have 10 American Indian coaches across the country. So we have some in Colorado, some in Minnesota, some in Oklahoma. So we have sort of an array of different tribes represented within our coaches. But I think it's a more global approach on American Indian tribes in general.
All right.
Yeah.
What about questions from you all as you heard all those new programming options? Well, I guess new, and then some that are not as new, but are still pretty cool.
A quick question.
Sure.
And we asked this question a few years back as well, but for the pregnancy services, is it safe to assume that it does not matter like what gender the person identifies as long as they are pregnant?
You got it. Yep.
Okay.
Yep. And again, much like behavioral health, we're not asking for doctor's notes or anything like that that says you are actually pregnant, right? So if they identify as pregnant, they are offered the pregnancy program. It is an opt-in program. They can opt in or out, but they are explained that it is an incentivized program up front and that they would get a dedicated coach. We have changed the verbiage to pregnant people and not just pregnant women. So we are trying to change, Susan, with the ever-changing times. But yes, it does not matter their gender.
Okay.
I noticed you saying pregnant people, and I liked it.
I was trying, yeah.
Additionally, if someone is wanting to have a family member enroll in the QuitLine,
Sure.
can they just call the QuitLine and still maybe speak to a coach just about supporting
Yeah,
their loved
absolutely.
one?
It's a great question. So we do have sort of a, if you will, a family and friends program where we do offer support and mailing materials to the family or friends that are calling in, and it talks to them about how to talk to their loved one about quitting nicotine, about, you know, kind of the dangers and the concerns. And then we if they want to, we mail them a sort of a packet. I believe it is in an unmarked envelope, as to not to spark frustrations if they get the mail and they're like, Colorado QuitLine, oh, here we go again, right? I can only imagine those conversations, but it is in an unmarked envelope. And we have a good handful every month, Susan, that are calling in on friends or family, or just general support. We won't enroll the person without their permission, right? I can't be like, my mom needs this program and you need to enroll her. Not saying that people don't sometimes go on the web and enroll their own family members without their permission, but we can only have control so far.
Okay, thank you.
Yeah, absolutely. Did I mention that it's a new web program? There's a new web program too. I know I mentioned it's a new My Life, My Quit program. Can't believe that, Keith. That's like been the biggest conversation for the last year and a half. So just so this team knows, on both My Life, My Quit and the web, we start with what the evidence shows. We're in an evidence-based program. We're an evidence-based hospital. So we went out and did focus groups and user groups and all of the groups that we could do across the country for our web and our My Life, My Quit program. We poured over these evaluations. We poured over what we see in the data. We poured over what we see in the text conversations. And we went back to the drawing board for both the web and the My Life, My Quit program. We've now built the web program to more digitally mimic the phone program, where they'll actually get badges and cheers and kudos for different things, different activities that they're completing on the web. Right now, the web program's really very self-guided. And it's, you know, do you want to quit? Do you have the motivation to quit? Here's some reading materials. I'm not saying our web program's ineffective, it's effective, but we needed to go back and sort of make it a little bit deeper and a little bit more engaging. So this program actually will give them kudos and for lack of a better phrase, rewards if they are completing certain steps along the way that, again, mimic more of a phone coaching program and identifying their triggers and identifying their motivations and all of those things. It's a complete revamp of the web program and a complete revamp of the My Life, My Quit program. And the web program will be going live soon. I won't give an exact date yet, Keith, but soon.
I love all the talk of the revamping and the revising. I like that slide that showed how like all the different milestones since 2002, because one of the points that I love to make in this forum all the time is that you hear a lot of bad news about the quit line. You hear, and it's just the case that tobacco cessation is extremely hard. And even the best case scenario, 6 out of 10 or 7 out of 10 attempts are going to be needed to be retried. And so there's always going to be bad news, but the fact is that the quit line has just gotten better and better and better over time. It's gotten more and more successful. And the quit lines of 2005 and 2008 are not the quit lines of 2024. And so I know that those of you who are out there in the communities are hearing back like the bad news from the people you're talking to. It's incumbent upon you to let them know that the quit line they called 6 months ago or 12 months ago or 18 months ago is different than the one today. There's new programs, there's new protocols, the coaches are better. I don't know if you even put on there that National Jewish has created its own internal tobacco treatment specialist program. So everybody's a TTS. That did not used to be true 5-6 years ago. It's true now. Like these are all new things that we're the ambassadors in our communities for the quit line, because Katie can't go out and talk to every Lions Club in rural Colorado.
You know, I'd love to, though.
Although you would love to.
Blow all these emails off and go talk to the people about the program. And you're totally right, Jim. The other piece of that is, to your point, the coaching has changed, right? We have gone through racial equity training. We have gone through LGBTQ plus community training. And these are required trainings that our coaches have to go through annually in order to stay a coach. In order to get their annual review, they have to show that they've done all these sensitivity and additional coaching training based on our coaching model that is ever changing and evolving to support the members that are calling in today.
And a lot of your, well, I don't know how many, but I know that at least some of your coaches are lived experience that are ex-users themselves.
Yes,
So,
correct.
and
I
that's,
would say a good 60 to 70%. That might be a high percentage.
which has probably always been true, but I think we appreciate the lived experience role
Correct.
more than we used to.
100%. Yep.
All right. Well, I'll let everybody else stew on their questions. I'm sure there'll be more percolating as we go through. But Keith, if you want to take over on the next step, thank you so much, Katie. We'll be don't
No,
leave.
thanks, Jim. I won't go. I'm here.
Yeah, thanks, Katie. It's always, your enthusiasm is really infectious every time you're talking about the QuitLine. So I always enjoy it, even though I've heard it many, many times. A couple of things that I just wanted to tag on with some exciting advances and that have happened last year. At the beginning of FY24, we started screening for menthol use. It was not something we were doing previously because we really had made steps to kind of keep the intake as brief as possible, so it wasn't much of a barrier. So we didn't have that question in there for a while. We added that last year, and then just kind of with the ever-changing tobacco and nicotine use landscape, this year in, let's see, July 25th, we added a screening question for nicotine pouch use because we know that those are growing greatly in popularity. So we really want to get a handle on that as well. And then I'm going to see if I can share my screen here. Let's see. Get the right one up. So this is just a very brief one pager that we put together that goes over everything that Katie talked about in a nutshell in terms of the different protocols. This was put together last January, so we'll be updating it here shortly. But this will go out with the slides as well, so you'll have this as a quick reference. It's also available on TFCO. You can find it there. Let's see. So we stop sharing that. A couple of other things I wanted to add about the menthol incentives. Katie mentioned that we added an additional 8 weeks of NRT for the phone participants plus the financial incentives. Web participants who are menthol users are eligible for an additional 8 weeks of NRT, but we are not offering the financial incentives through the web because we really want to encourage people to engage with coaches, to use the phone program. The outcomes demonstrate that there's a greater chance of success when they are working with a coach and medication versus one of those alone. So that's the reasoning behind offering financial incentives for the phone only. If you were unable to attend Public Health in the Rockies, Tiffany Schomer, Dan Simon, who is the STEP epidemiologist, and myself did a presentation on the menthol protocols and offerings. So those slides will be in the upcoming STEP newsletter. If you wanted to check those out, there's some preliminary data on the success of the program this far that you can see in there. And then in addition to that, starting next month, we are going to be offering the same incentive structure, the same financial incentive structure for individuals that are Medicaid recipients. So they'll be eligible through the phone program for the $10, $15, and $25 gift cards for completing those first 3 calls. We're really excited to be able to extend that offering and based on the success of the menthol offering. So we'll see kind of how that goes moving forward. And both of these we're planning to keep as a part of the program. These aren't limited time offerings, but really want to make sure that everyone's aware of that. I've been meeting with Medicaid provider organizations that are just to make sure that they're aware of this. We're doing some promoting of it over the next few months as well. So really trying to get the word out about that. Then last thing I want to do is just walk through I just want to walk through how you can access your data. So for your county, you can also look at statewide data for the QuitLine. National Jewish does an awesome job every month of sending us very detailed reports, everything from the youth program, I Left My Quit, to we can look at statewide demographics. Depending on the size of the data pool, we can look at more localized demographics, but obviously PHI needs to be protected. So there are limits there, but I'm just going to walk through real quick how you can access the data via the TFCO website. I also put all of this information in a PDF that will go out with the slides after this, so don't freak out if I'm going too fast. So let me find the right one. All right, so here we are on the TFCO home screen. I'm logged into the grantee side of things. And I'm going to scroll here to goal areas, and I'm going to go down to cessation, and I'm going to click on cessation. And then in these big bold letters here, we see click here for all QuitLine related resources. So try to make that as easy as possible. So we click on here, wait for my Wi-Fi. And then I'm going to scroll down. These are just some of these are previous learning community calls. What I just showed you of the offerings, that colorful sheet is right here, so you can download that there. If we continue to scroll down, just based on the order of these, I'm going to go all the way down to the bottom until I find QuitLine Reports Archive. And I'm going to click there, and this takes us all the way back to 2016 through FY25. We have reports, monthly reports. So you can click on the year that you're interested in. So we'll do last year, FY24. We'll just kind of look at some end of the year things. And then each month, you'll see there's a whole host of reports in here. These dashboard will really give you kind of just an overview of what's going on. So if we look at, this is the Colorado dashboard for year to date, fiscal year to date. So the whole FY24. And if I open that up, I've got phone intakes, web intakes, and this is all statewide. So this just kind of shows you who's interacting with the program, how they're interacting with the program. It really kind of gives that big picture. I think some of this in particular, and then let me show you a couple other that will be useful for you. The Colorado demographic summary comes out on a monthly basis. And this shows enrollments by county per month. So this is just unduplicated intakes. This is lets you know kind of your numbers, how it's going month to month. You can use this if you're doing local media campaigns that are promoting the QuitLine. You want to see if there might have an impact or a bump in the enrollments there. A lot of useful information in this one. And then the last one, the intake demographic report. This is monthly also, but statewide numbers, but shows really the demographic breakdown of the enrollments that the intakes that we saw at the QuitLine for any given month, or this one happens to be for the year. What did so that was really quick, but I want you to know, obviously, that you have access to this. If you need to log into the TFCO, you can reach out to Chelsea Andrews. She can get you set up with that. Obviously, if you're having trouble in here finding things, please reach out to me. I'd love to either set up some time to walk through this with you one-on-one. I can pull, like I said, more detailed reports depending on the size of the data pool. But these are really great options for you all to evaluate how the program is working in your community, to look at how your promotion is working in the community, where you might want to target some of those efforts. But please make use of this data because it's there for you and it's super helpful. And if you want to set up a one-on-one with myself or Jim or Katie, and we want to talk through some of this, we'd be happy to look into a time to do that. And that was really all I had, I think. So I'll see if anybody has any questions.
Jennifer has asked if they can get the flyer for the Medicaid gift card program. Is that available?
That's starting next month. So we haven't created any of the promotional materials just yet. But when we get those ready, we will certainly send them out.
Okay, great. Thank you.
Great. Other questions for Keith or Katie? Because I'm about to get real boring.
Impossible.
Impossible. We'll see. All right. I'm gonna go ahead and share my screen. Now it's really hard to just say like, oh, here's all the data that Keith just showed you where it is, and then just tell you like, here's how to use it, because your ability to go through the data and to start making your own charts and graphs and all that kind of stuff it's dependent on your staff capacity needs. It's also dependent on your programming goals. What do you want to be working on? So I just have, I'm going to show you some of when I was going through the archive that Keith just showed. These are some of the ideas that I came up with just from the outside looking in. And there are almost certainly better options once you come up with a more specific program goal. So some of the slides you're going to see the same things. Now, I do want to point out that Keith showed that the archive goes all the way back to 2016. And so if you really are interested in pulling this data down and tracking certain numbers of it, I wouldn't say do it to all of the data, but if you wanted to track trends to see how things have changed over time, it's certainly available to you. It's going to require a little additional work because all the data is up there. Most of the data is up there in PDF format. But then again, you're also not going to need every single one of these variables for most of your program contexts. There are, as Keith said, most of the data is statewide data. And there are still two good reasons that you might want to consider statewide data. One is because whatever's going on statewide, there's a good chance that something like it is going on in your county. Now, the numbers aren't going to match up, obviously, but the trend lines should more or less be pointing in the same direction. And if not today, then maybe tomorrow. Some counties lead and some counties lag. The other reason to look at the statewide data is that you can see what data the QuitLine is collecting and reporting back, which can give you programming ideas. And this is the first one. This first slide is an example of the latter. So this is the referral summary report. This is what it says if you were to go into that archive that Keith showed. It says referral summary report, and this is what you would see. And what I'm pointing out here is that there are a lot of different ways that a referral can be closed. So a lot of times it's closed because they are enrolled, and then the referral part is closed. The reason that a referral is closed is because they're they couldn't read it. They got it and they're like, I don't know what this says. So it's done. It's dead in the water. And then look at the bottom line, which is the unreachables. Both illegible and unreachable are ideas that you can approach in your 5A's trainings. When you go out to clinics and you're training providers how to give proper referrals, you can let them know that if they can't read those referrals, they're dead in the water. They're not going anywhere. And there are also strategies that we will discuss next month when we do the 5A's training on how we can reduce, we're never going to eliminate, but how we can reduce unreachable. Because unreachable is exactly what it sounds like, right? The QuitLine receives the referral, and then they're going to try to call that person a couple times, a few times. I think it's 3, Katie, is that right? 3 times. And then if they don't answer, they're 5 times outreach. 5 times, which is a lot. They're going to say like, okay, well, we couldn't get a hold of that person. And there's a couple different reasons why somebody might not be answering their phone. The two big ones are they gave the wrong phone number because they weren't really interested in receiving that phone call. And the other one is that they're screening their phone calls and they're not recognizing the number that's coming in. And so we need to train the providers to train their patients on what to expect regarding the QuitLine outreach they're about to receive. And then 71, I think is what it says. Now I have it covered up. 71.5%. That's a little high historically. When I first started collating data like this for the QuitLine back in 2014 or so, it was closer to 65. So, but still around 2/3 of referrals are lost to being unreachable, and that's high, and we can address that in our trainings. The other reason is to compare yourself and start being able to set benchmarks for your programs. So Keith showed you this one. This is the Colorado dashboard. And this has got racial and ethnic breakdowns. It has financial and insurance breakdowns. And again, this is another situation where you can kind of see what's going on in the state. And whether or not you'll ever know, you can assume that something like this is what would be happening in your county should the numbers get large enough. I'm pointing out the map got cut off when on the one that Keith opened up. I'm bringing up the map here just to show you that I actually kind of find this map a little bit useless, just because it's always going to be really dark where the population centers are. And what you want to do, and I'll show you this later, is adjust for your populations. You want to adjust for the prevalence rates in your county. And I'll show you how I would do that in just a second. Don't compare your counties to the darker counties here, because you'll just never catch up. If you're a small county, if you're one of the dark counties, then of course you're caught up. The QuitLine is collecting various medical pieces of information. This may or may not be useful. It's useful to them because they're using it to navigate treatment options primarily, and also rule outs, precautions, and those sorts of things. But these are also potential population targets in your county. You can go to clinics and say, what I'd really love to do is focus just on your asthma registry, just on your heart disease registry, just on your cancer registries, and see if we can drive these patients into the QuitLine. And then you are confident knowing that the QuitLine is able to appropriately respond to those particular medical needs, because they're collecting that data for a reason. I mean, and some of it's very minor, like the one with dentures at the bottom. That's going to be a precaution against the nicotine gum, right? Dentures is a problem for those particular users, and so they're collecting that data to make sure that they don't recommend the gum for those particular users. So you don't need to go to your dentist's offices necessarily and say we would like to drive up QuitLine calls from people with dentures, but from a training perspective, when you go into a dentist's office, you should also know that patients with dentures are going to have specific needs when it comes to their nicotine replacement therapy options. This is the bottom. Keith called this one up. This is the state line demographic report. I went to go further down just to show you that there are some things that we can really see here. Now, I'm jumping the gun a little bit, but because 2 data points does not make a trend line, but you can see that in July, 1 person using the nicotine pouches called the QuitLine compared to 14 in August. So is that going to go up in September, October, November as those numbers come in? It's worth looking at. And if it's happening statewide, there's a good chance that it's also happening in your county, or it's going to. And so we can sort of, this is some of the things that we can get from the large numbers that the statewide population gives us that we can then start to get a head start on some emerging trends. This is the insurance payer breakdown. The big takeaway from this slide, although it's messy and I know it's impossible to read, it'll be easier if you call it up on your own. The big takeaway from this slide is that Medicare and Medicaid are your big insurance payers that are going into the QuitLine, right? That's going to be true everywhere. Then there's a couple different reasons for that. Number one is that they're big systems, right? And all the other systems are all the other systems, so they're just naturally going to be smaller. But if you start to see big trends, and this will get clearer as the year goes on, so you can go back to previous years and kind of see this stuff. If you see that certain payers are having additional denied claims, if you see that their callers don't seem to be getting past call 3, if they're not accessing certain nicotine replacement therapies, there's a good chance that what you're seeing there is that those are not offered to them in the third party payer lines, which might make a difference to you. It might be impactful for you if you are, especially in a small county with a large employer, and you know which insurer they're using, because then you have a different way that you can address their audiences or address the population in your county when you talk about the QuitLine benefits that they may or may not have access to. But then we get down to the real stuff, right? This is the county level report. This is where most of your attention should be at. And so here, the counties here, we're only the 2nd month in. And so you can see that the counties that are represented 60 days into the fiscal year are the top 10 most populated counties in Colorado. I would like to see the rural counties pop up here, and they should over time. One thing that you can see is that even in these big counties, like 500,000 people, there's only 36 calls coming in per month, right? So we'd expect, I don't know, there's like this expectation of how much data we're actually able to collect when there's only 36 per county, and this is a large county. You can understand where suppression might come into play. If you have one person who's coming in from your county, some of that data is going to have to be suppressed because we know who it is, right? So it becomes a problem. But here's what I would do with this. This is good. This is good for benchmarking what your outreach strategy goals should look like. So, and this is what I would think about. Here's the top 10 counties. These are the same counties that are pictured on the other slide. Here's the population of those counties. Now, of course, I noted they're all very large. This is the prevalence data from 2022 for each of those counties, and you multiply the prevalence data by the county population, and that's how many smokers or tobacco users there are on each county. Right now, if we take that number and divide it into the calls of QuitLine, that's how many smokers, what percentage of smokers, tobacco users from each of those counties has called the QuitLine in the last 2 months. And so if you quickly do the math on this, there's more math you can do on this table. And what you find out is if you multiply those numbers, that 0.08, 0.08, 0.12, et cetera, by 6, that each of these counties is on track to getting between 0.6 and 0.7% of their tobacco users calling the QuitLine over the course of the year. That's a pretty good average, right? And so that becomes a good benchmark for you. If you figure out how many tobacco users there are in your counties, you would kind of have an idea of what your QuitLine referrals should look like or what you can target. Which is not to say that these counties are performing optimally or that they're performing poorly. It's just, but that is what the current performance level is good or bad. And so you can start there. And if you think you can overperform that, then drive your benchmarks up. But that's how I would start thinking about my programming outreach goals, is to try to get that number, whatever that is for your county. And then the next one, and maybe the most important one from a programming point of view, is the clinic level report. And so this is a situation where you can identify all the different potential referral sites in your county. You can identify what those are, and then do they show up here? And if they don't show up here, now again, we're only 2 months into the year. If they don't show up here, do they show up at all in 2023? Do they show up in 2022? Do they show up in 2021? When was the last time any of your referral sites showed up on any of these figures? And not just who's laggard, who's lagging here, who's just not seeming to participate in your QuitLine, that might benefit from you reaching out to them and getting them a 5A's training, but also who's excelling. Is there a clinic that just keeps showing up here that always has good numbers for your county? Because they might be good representatives. Rather than thinking about going to them and offering them a 5A's training, you might think about stealing their chief medical officer or their nurse navigator, whoever's doing those referrals, and seeing if you can get some tips and tricks for the other clinics that are in your vicinity. But obviously, this is the one that we want to, and we can track a lot of different things here. We can just track the referrals from the guys and girls who are showing up here, and also doing that before and after you do 5A's trainings with them, to see if that training had an impact, and then if it had an impact, does that impact last? If you see that they have one every other month or so, then you do a training and they have 5, but then they go back to one every other month. What happened, right? Because we can always go back in and refine our training to be more responsive to their needs. If we see that a clinic, and we'll talk a lot more about this in the 5A's training next month, but we can always ask, most of our clinics, most of our providers, they want to do this. They know that tobacco use is the number one thing that's going to kill their patients. It's causing chronic disease. That's complicating the cases that they're trying to manage. They would love for all of their clients or patients to stop using tobacco. So if they're unable to do these simple referrals, why? What is the system level barrier that you might be able to help identify and then resolve for them? And sometimes it's incentives, sometimes it's time, sometimes it's training, sometimes it's any number of things. One of my favorite examples of little tiny things is back when Denver Health was building their tobacco cessation clinic, their providers kept saying it takes too long to make the referral. And this is back when everything was fax to quit. And what they did was they printed little stickers that filled out the top part of that form for them. And so it reduced the amount of time it took to fill out a referral from 2 minutes to like 45 seconds. And then their referrals went up. That's a little tiny thing. And it doesn't take like a super genius to figure it out. What it does take is somebody who's curious enough to ask why they aren't doing it, and then to be creative enough to come up with a solution for them. So at any rate, obviously, I think a lot of people already know that that this clinic level report does exist. And if you didn't, there it is. And then, the next phase of this is, if you know for a fact that clinics are making referrals and they're not showing up here, then that's a good time to come back to me or Keith, and we can try to figure out why that's happening. And I went backwards. And that's it for me. The chat has lighted up here. Yep. Yeah, so Annalie has asked, and this is a question for either Keith or Katie. Are these reports something that we can share with our community as is, or are they something that we need to summarize, communicate the data from the reports to the community in our own way? Oh, I see that, Keith, do you want to answer that out loud, Keith?
Sure. Yeah, I think it's a great question. I really think that it makes sense to take the reports, to kind of personalize them for your community, to take the data and really present it in a way that's going to resonate with the community, versus just like, hey, here's the numbers for last month in the QuitLine, because that doesn't really tell the story. So kind of framing that in a way that is perhaps directing who you're sharing that with in the direction you want them to go. So framing that data rather than just giving them the numbers, I think is going to be a lot more effective. But excellent question.
Great. Other questions or thoughts or pushback, commentary? Happy to take it all. This is a safe space. We're all here to learn.
Hey, Jim, can you hear me?
I can. Hi, how's it going?
Hi, great. How are you?
I'm excellent.
I am very excited to see that this is being shared out. We did this a few years back on a separate project, and I did notice that sharing it with the individual providers or organizations with like a customized kind of slideshow just for that organization, even just showing like trend lines, like taking their specific data, going over a few months to see, if they're going up or down. The clinics really liked that specific reporting, and I think it's helpful to them to see where they're at, and then you can help them also identify how they might improve.
Yeah, wonderful. Thank you. And it's so true. I when I worked in community behavioral health, we would get data reports like those all the time. And so just to double down on what Keith and Angie both have said, is I hated just getting a bunch of statistics and then it was like, then what? They're like, oh, well, we got 67 intakes for depression last month. I'm like, so what? Is that good, bad? Is that high, low? Or is there something I'm supposed to do with that information? And so caging around what they may actually do to improve the figures that you're showing them is important context to provide for them, because they don't have time to think about this stuff. They're there for they're not just there for the data dump. They're there for the actions. So are there county level lists of clinics signed up to make referrals, or do we just find that through the data you showed? So, well, I don't know if the QuitLine hosts anything like that, but no, and I would normally do that as my own search, that you would just find the healthcare providers in your area. I would start with the hospitals and the community behavioral health organizations. Then I would drill down into smaller private clinics. And then if you happen to know of private individuals, that I would list them as well. Katie, you guys don't keep anything like that? No, I didn't.
I wish we had a master list. It would be really amazingly helpful. Some of the things that we've explored in additional states, and Keith, you and I can kind of talk through the logistics of this, because I think in Colorado it may not be quite strategic or logistical, but in the provider web referral form, we can create a drop down menu of all clinics so that they can select, and helps clean up the data so that you don't have capital ABC clinic and lowercase ABC clinic, but managing that sort of list of clinics, and then of course providing an answer of others so that they can list their own. It just becomes a little bit of a data nightmare, but certainly something we can explore.
Well, and then also just to kind of read between the lines there too, clinics don't have to be signed up to make QuitLine referrals.
Correct.
They just can make
Correct.
QuitLine referrals.
Correct. And just to make one more clarifying point, on the web, as I had mentioned, there's a community referral form. If they happen to navigate to the provider referral form, they can still also make a referral. We're not trying to bounce them all over. We're just trying to make it either easier. As long as they choose non-HIPAA covered entity, they can still utilize that provider web referral form. So it's clinics, obviously hospitals are the crux of who's referring. But if you have WIC centers or food banks or unhoused shelters, you can certainly talk with them as well as community members that can help engage participants that might need help.
And then it's any HIPAA protected entity that qualifies for the faxbacks.
Yes.
But HIPAA protected entity is a really ambiguous, weird legal term. So do they just have to claim that they are a HIPAA protected entity? Do they have to prove it in some way?
No. Great question. We sort of take them at their word. So if they say they're HIPAA covered and in fact they're not, well, that HIPAA breach will lie on them, not us, because of the information. I mean, that's just the legal requirements, I guess, on our side. But
Right.
yeah, we're not saying like, hey, what's your HIPAA ID number or what? I don't even know if those exist, but I like to make stuff
They
up.
don't. It wouldn't be such a word legal ambiguity if they did.
Right. Right.
We can go through a whole webinar.
Really gray area. Exactly. So, But yeah, just know my rule of thumb when I'm presenting is if you mark HIPAA, you're getting information back that you're responsible for. So, do with that what you will.
And something else is as you're going through the data, you'll see that there are some incongruities. You'll see that you'll look at the demographic numbers and they're much higher numbers than what you'll see showing up in the referral sections from your county or even the statewide levels. And that's because people can enroll themselves. So there are more people than are referred to by clinics.
You got it. Yep.
So yeah, if you're going through the data and you start getting weird questions like that, because I could have done a presentation just on weird questions about QuitLine data, but I didn't want to go.
I may not have shown up to your call if that was the title of it.
Yeah, right. But those they may or may not be program salient, and so if you're going through them and you're like, what about this? What about that? Reach out to me, reach out to Keith, and then and if we can't come up with the answers, then we'll go to the QuitLine ourselves.
Yeah, there are so many nuances in the data that it's not always black and white. You can go down the rabbit, like race and ethnicity. They can report more than one, right? So that number is not going to necessarily match the number of people that enrolled, and sometimes that puts people down a rabbit hole for days. So
and you like double count if they want the phone or their phone exclusive if they like the web and their phone exclusive, and then there's a Venn diagram where
there's a phone web. Yes, exactly.
Yeah,
exactly.
So there's all sorts of weird questions, and sometimes you can just struggle yourselves cognitively through the spreadsheet and probably come up with an answer, or you can rely on those of us who've already done it and just ask us if we have an answer.
Or then Keith will say, "Hey, Katie," I'll be like, "Shoot, now I get the data analyst involved every time. I don't even try to make a guess, just so you know. Nope, somebody's smarter than me. Here you go."
Not smarter, better informed.
Right, there you go. We're math informed.
Great. Well, we are within the last few seconds of time. I don't know that we'll have time for another question, but if you do come up with other questions, please go ahead and email them to me. I will get the slides. I already have the slides from Katie. Thank you, Katie. Keith only shared the one slide that is available to you through Tobacco Free CO. So I'll get mine and Katie's slides together, and those will be available for you if you'd like them. I'll have the video on BHWP's YouTube channel by the end of the day, and I'll submit it to Tobacco Free CO, so it should be up there within the next 5 weeks or so. Otherwise, thank you all for showing up and for your questions and your attention, and we'll see each other next month for a 5 A's training.
Thanks, Jim. Have a great day, everybody.
Thank you, Keith. Thank you, Katie.